Alrighty, good morning everybody. We're going over our EKG of the day today. And so this is kind of a case, I'll say, just to blend in some topics. So this is a 24-year-old male with new onset palpitations, maybe with some lightheadedness. That started about 4 hours ago. Okay. So let's take a look at this EKG. First thing I do is I look at the trees and I just look at the QRSs. I'll look at lead 2 down here, and you see it's a pretty fast rate. It appears to be somewhat regular. And the average rate looks like it's about 300, 150. So maybe around 150 beats per minute, maybe 155. Okay, so that's just kind of a general idea of this rhythm. It's tachycardia. So is this a tachycardia coming from the atria or the ventricles? What's going on? Well, we've got these narrow QRSs. We know that if it's a narrow QRS, that we know that it's likely coming from the atria through the AV node and down into the ventricles, or so we know that the ventricular depolarization aspect of it, or this QRS aspect, is coming from the AV node. And using the His-Purkinje system allows for the ventricular depolarization to occur in a short period of time and have a narrow QRS. So that kind of narrows down our focus. And so let's see what the atria is doing. Let's just march down our algorithm here. And I'm looking for P waves that are kind of discernible. And I don't see any consistent P wave that looks, the same. We're looking lead 2. And if you notice, we kind of have this, you can see this little bit of this sawtooth pattern. So we think maybe is this atrial flutter? It appears to be kind of somewhat fluttery. You always can look in V1 if you think it's atrial flutter, and look at P waves, and so P waves that are caused by these flutter waves. It's very close, but ultimately, atrial flutter. The reason why I would say this isn't atrial flutter is because you can see that these flutter waves should be monomorphic the entire time. All of these flutter waves should look the same. You can see there's kind of moments where the flutter waves, the morphology will change. And so you've got flutter waves over here. They're kind of changing. They're not perfect flutter waves. You can look in V6 here. We've got what looks like some flutter waves, but maybe. So this is hard to say. It definitely has some flutter-like activity that looks like it would be almost 2-to-1 conduction. And this looks like it could be a 3-to-1 conduction here, where you have flutter, 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 QRS. But ultimately, I would say that this would be more of a coarse atrial fibrillation. And so that's a coarse AFib. And it's okay, because when you're looking at this rhythm in clinical scenario, you don't need to say, is it a flutter or is it coarse AFib, in a sense that it's not going to really change your management. And I'll explain why. And so, okay, we saw that there's no sinus P wave. We're looking at our QRS axis here, and we see that we've got QRS that is up in lead 1, up in AVF, so we know it's going down to the left, so that is normal axis. So we say this is kind of this course, AFib, a rate of 150 beats per minute. Now I don't see any major evidence of ischemia here. And so this 24-year-old sitting in your one of the ER rooms, and so what are we going to do? And I thought this was a good case to see, how can we confirm, this AFib? And so, we know that with narrow complex tachycardias, if they're unstable, we would sync cardiovert or shock. And if they're stable, we can slow this rhythm down and then make a decision on if we feel comfortable converting this individual electrically or pharmacologically. And there's some nuance to converting new-onset AFib. We can do these scoring systems to see what's the risk of stroke and, when did this AFib start? Do we know exactly when it started? What is the risk of developing a thrombus? And so what should we do? We've got this stable gentleman. Let's slow this rhythm down. And so what are some medicines that we can use to slow this rhythm down? Well, remember the rapid response. If I come to my chart here, AFib or A-flutter is a disease of the atria, sending signal rapidly throughout the ventricle or throughout the atria. And every now and again, it'll bump into the AV node and send a signal down. And then this fibrillatory waves continue, and then they bump into the AV node and they send the signal down. And if you're young and healthy, then you can have AFib with RVR, where the ventricular rate is increased. The ventricular rate is increased just like we see in this individual. And so it's all about the health of this AV node. The AV node is what's conducting the signal down. The atria are going to continue to fibrillate and bump and send signal down, and fibrillate and bump and send signal down, and send signal down. And so it's the AV node, however fast the AV node's going to conduct that signal is how fast our rate is. So if we want the rate to decrease, our goal would be to slow the AV node. Well, there's a couple ways that we can do that. We know that the AV node has one sympathetic innervation. And then we know that sympathetic innervation to these nodes increases the rate. So what if we blocked this with a beta blocker? So we could give a beta blocker like metoprolol to this individual, and that would likely slow it down. Or we know that the AV node, if I took my AV node, if I drew the action potential of an AV node, you've got pacemaker potentials, you've got sodium channel, and then once it hits that threshold, you'll get more rapid depolarization through our calcium channels, and then repolarization from our potassium channels. So if I want to slow the conduction here, we know that our AV node is very calcium channel dependent. So AV node is calcium channel dependent, meaning it can really slow down the rate of depolarization and the rate of signal conduction. And so we can give a medicine that would block these calcium channels. And we know that these calcium channels are non-dihydropyridine calcium channel. And so we give a calcium channel blocker. Then we can slow the AV node down. So in this case, an example of an IV would be diltiazem. PO, you can give verapamil, but IV diltiazem. So in this case, we decided to give 30 milligram bolus of diltiazem to this gentleman. Let's take a look at his EKG. So this was his EKG 30 minutes after the 30 milligrams of diltiazem. And let's take a look at what it looks like. So first thing we're going to do is we're going to look at the trees. We've got this narrow QRS. The rate is definitely slower. You can see the rate is anywhere between 300, 150, 100, maybe 95 to 300, 150, 175, maybe 70 beats per minute. So not tachycardic anymore. Well, let's see what rhythm he's in. And you can see as I look at P waves, I don't see any good P waves. I don't see that sawtooth pattern anymore. So this is AFib. And so going back to our previous EKG, where it was hard to determine is this AFib versus a flutter, sometimes you don't really know until you slow it down. Once you slow it down, you get a better look at what the atria is doing, because that calcium channel blocker shouldn't really affect atrial depolarization very much. It just affects the AV node. And so from here, we can do the rest of our evaluation, and we see that we've got QRSs that are still up in 1, up in AVF, we've got good access, we have no signs of ischemia, and our patient looked a lot better. Patient was less lightheaded and was feeling a lot better. We actually consulted with the cardiologist. We discharged him for a follow-up, a close follow-up with the cardiologist, and he did not require anticoagulation because he was young and healthy. It didn't meet any of the risk factors for having a stroke. And so I thought this was a good example of a case where understanding the pharmacology and the physiology can help you kind of work through, well, can I say what this rhythm is? If not, what can I do that's safe for the patient to help me determine what this rhythm is? And so we know that either AFib or A-flutter, they both send signal down the AV node in the same fashion. The difference is AFib has these fibrillatory waves that bump in, whereas A-flutter is this flutter wave that goes about the tricuspid annulus, and every time it goes around, it sends a signal down. Every time it goes around, it sends a signal down. Sends a signal down. And so similar to AFib and A-flutter, you would also want to slow down the AV node if they were tachycardic. And so that's our EKG of the week, and I hope that helped.